Good evening and welcome to tonight's BOMSS educational webinar entitled Setting Up Adolescent Bariatric Surgery. I'm Professor Rachel Batterham and my co-chair this evening is Mr. Chetan Palmer. I want to start by thanking Ethicon for sponsoring today's webinar. Throughout the lecture, please remember to post your questions in the live Q&A section, which is down the bottom on the right-hand side, and we'll be addressing your questions at the end of the talk. And I'm going to hand over to Chetan to introduce our speaker.
Hello, and welcome all again. Thank you, Rachel, for the kind introduction. And I think I'm going to introduce Dr. Ashish Desai. I think, first of all, he doesn't need introduction. He's one of the pioneers in setting up and doing adolescent bariatric surgery in the UK. He was working in King's Hospital before, has recently moved, and is actually setting up his own adolescent bariatric surgery again. And I get that that's what he's going to talk to us about and teach us. So without taking more time, Ashish, Zoom is yours.
Thanks a lot, Rachel, Chetan, and BOMSS for inviting me to give the talk and to talk about the subject which is closest to my heart and which has become my life. That is pediatric bariatric service. We all know that the bariatric surgery first time was operated in 1954, but the first laparoscopic bypass started in 1994. And pediatric surgeons were not, or rather pediatric bariatric surgery was not far behind, because in Australians started doing a randomized control study of band versus lifestyle changes in 2005. And in 2007, the Americans set up a teen lab study, which is a longitudinal assessment of bariatric surgery. And they have recruited 240 teenagers between 5 centers. And all the 5 centers have been pediatric surgeons operating on these patients. UK was not far behind, because UCL has done or published that 11 cases ranging from 15.5 years to 18.6 years. And Sheffield started doing them in 2004. They have published their results of 6 patients over 8 years. I joined King's in 2008 and started thinking or started talking about setting up pediatric bariatric service at King's. In 2009, obesity surgery in children was a taboo word. It was not only the media, which was talking about how we are offering a costly gastric band surgery over a weight loss course, but also my own colleagues who wrote back these kind emails to me saying that this sort of surgery is an abuse of principles of the NHS. And also one of them is asking me whether surgery is an answer and all that people need is to control their diet. So there was no pediatric bariatric service in UK, and there has been no training. And therefore, I went across the pond, went to Cincinnati and Columbus, Ohio, and also to Chicago. And having learned the basic tricks of trade, I came back here and started assisting my adult surgeons. And I cannot thank Amit and Avril, who started giving me the training about adult how to do bariatric surgery. I then started operating these children in my list along with adults. And by that time, Francesco Rubino had joined the service, and they all helped me, and Sasi as well, Sasi Ramar, all four of them had helped me how to do these finer tricks of the trade. And then I started operating independently. In 2010, I got the management approval and started doing the first case in 2011. In 2012, I got the American surgeon to come down here to do a live operating workshop, and followed that with a first international meeting about pediatric obesity from prevention to surgery, and did the same thing in 2015, by which we had already started setting the standards for pediatric bariatric service. In 2017, I gathered 40 surgeons, pediatric bariatric surgeons from across the globe in UK, in London, trying to set up a global adolescent bariatric surgery network. But when I started talking about adolescent bariatric service or pediatric bariatric service, the question which I was asked was, why? Why do you need to do this whole gamut of setting up bariatric service? The adults can do them. As I showed you in the first slides, people said we could operate them. Maybe they need to wait till they are 16, or maybe they need to wait till they're 18, but we can always operate them afterwards. What's the problem? The problem was, and before I talk about that, let's find out, if I could, there is a poll which should come up on your screen about if this was the patient, which is if there's a patient with 163.8 kilos, with BMI of 63, had a fatty liver, had been pre-diabetic and insulin resistant, had sleep apnea, and had started developing diabetic retinopathy, and was well assessed by a physician, a dietitian, and a psychologist, who all said that this patient is appropriate for surgery. How many of you would consider doing the surgery in this patient? So, and actually they've just answered the first two questions, because the third question is third and fourth depend on this one, which says the same patient, but if that patient happened to be a 13-year-old, how many of you would plan the surgery? So if you could answer the first two for the, basically, if this patient in a general adult population, if that patient came to you, what would you do? And if this patient happened to be 13-year-old, what would you do? But my need for the pediatric-based service was set up right in the beginning. Just when I had set up my first patient, I got this call from an orthopedic surgeon from Belfast, who said, Ashish, I need a help. I got this 13-year-old boy who has osteogenic imperfecta type 3. He is in nappies for the last 5 years, and he's breaking bone every time he's moved onto the toilet seat. He has had 99 fractures in 5 years. And I have been going to my colleagues and asking if anybody could do anything to this. And I was told there is nothing which can do. As it happened, one of our trainees who knew that I was setting up the service landed up in Belfast and said, oh, go to Ashish. He is so, probably you could say mad, to probably do the surgery for this patient. And as you can see in this, the osteogenic imperfecta type 3, which is what this patient had, is in red. And you can see that this is the 50th centile, this is the 95th centile, and the patient is sitting way above that. for an OI type 3. This patient had such a thin bones that we could not even see a bone in the x-rays. And that's when I got the American surgeon, Tom Inch, to come and give me a hand with this patient to do the surgery. And then the floodgates opened. I had a 215 kilo patient being referred from other parts of UK, and an achondroplasia with BMI of 63. This is not her picture, but this is what she looked like. And she was wheelchair bound because of the problems on the bones. And we already had an IPEC guideline, which said that it is exactly like an adult guideline, which said the BMI of 40. We would normally put the centile charts to say centile about 99.6, and where the all other things that remain exactly the same. All non-surgical measures failed for more than 6 months, and has a specialist service. Nice guideline, mirrors this, but says it should be done under exceptional circumstances. And this was just the beginning where I had started crossing the hurdles, because I had the full support from my management. I had a full support from my adult surgeons. What we needed was a support from the NHS England, because at this point, all these 3 patients I had to do on an individual funding request basis, where I would apply for the funding and I would usually be told, no, you cannot do it. So, but then I started working with NHS England, got the Pediatric Bariatric Surgery CRG, and then we set up the clinical commissioning policy as well as service specifications. And following that, in 2017, we managed to get the approval for adolescent bariatric service. And now, instead of needing an individual funding request, now it sits with the specialist pediatric surgeries CC group. Recently, I've also been involved, so my involvement continues in children and young people, and I've been member of the Obesity Tier 3 Task Force. And as some of you might know, we have been having the Obesity Tier 3 being set up all across the country. To set up a service, I again leaned on my American counterparts to look at how to set up in high quality adolescent bariatric specialist centers. And if you look at the MDT, you need a bariatric surgeon, either a pediatric surgeon with bariatric interest or a bariatric surgeon with pediatric interest. And we are not yet sure how we can say whether the bariatric surgeon has a pediatric interest or not. I believe they should do it along with a pediatric surgeon. The pediatric, we should also have pediatric specialist with interest in obesity or bariatric expertise and related pediatric subspecialties, mainly endocrine, pulmonary, GI, as well as cardiology. We should have a psychologist as a part of the team, because all children undergoing the surgery should have appropriate assessment, and I'll talk about what assessments. And the highlighted team are the essential components, and the rest of them should get involved as per the need. The pediatrician's role is to identify severity of the obesity, to find the cause of the obesity, make sure that this is not something which is treatable like hypothyroidism, look for comorbidities, look at the social history, family history, and to treat the appropriate comorbidities. The other specialties, as we know, almost 33% of children with obesity will have OSA or exacerbation of asthma. And the type 2 diabetes is also increasing in children. The dietitian's role is to assess the diet, to prepare and monitor the diet plans before the surgery, and also to go for the liver shrinkage diet, which I prefer to have, and to make sure that the post-op diet plan is followed. these children, our dietitians have been using the various apps to work with the adolescents because they do not work normally, as in they would not be responding to telephones or texts. But they are very happy to use an app where they can put their data on. A pediatric nurse is a very important component because she's the point of contact. They have a good coordinate the team and the follow-ups, and they can be used very efficiently for the research and academics. The pediatric surgeon's role is as a team leader because we do work very closely in small spaces. I do laparoscopies in, 2-kilo baby, or as I did over the weekend on a 10-month-old child with grossly distended abdomen with Meckel's diverticulum. So we do quite complex surgeries. It is pediatric surgeries, not only about hernias. We choose the appropriate procedures, and personally, I would normally resort to sleeves, mainly because I'm a bit worried that these children will not follow the dietary guidelines and take the multivitamins for the rest of their life. And in around 10% of the patients, if this was to fail, at least they might be able to have other procedures, which gets restricted if you've done a bypass. But pediatric surgeons are also important because, as I have been working quite constantly to educate the people, to mobilize the public opinion as well as the opinion for the healthcare workers, and to set up the service. When pediatricians are looking at that, what we are looking at is, or the whole team, is there a reasonable effort to lose weight in the past, and what actually worked, what did not work, whether there is associated comorbidities, is there good family support, is there an active psychiatric illness or drug abuse, which is where the psychologist will come into the play, and whether they have been adherent to medical, nutritional, and exercise regimes. The way I look at it, most of these patients stay with me for almost 6 months to a year before the surgery, and therefore it is a good time to assess whether they are likely to follow things. At least it is difficult, what we all know, that if the patient followed a pre-op advice, they may not follow the post-op advice, but if they have not followed the advice even before the surgery, they're unlikely to follow it after the surgery. And we look at the maturity of the person, both chronological, whether it is physiological maturity or a psychological maturity. And that's where the psychologist comes into the play, because their role is to look at who will do well, understanding whether they understand the procedure and what their expectations of the procedures are, who will need additional support and who is not appropriate. They look at the mental health of the person and also look at the informed consent or assent, whether there is benefits, as I said, and making sure that this assent is without the parental or family coercions. They also look at the family's understanding as well as importance of the follow-up, whether they understand it or not. We have also discussed in the past about whether is there a legal or non-legally binding consent form or a contract between the family or the patient and us would help them in getting that contract, whether if they signed a contract, whether they will feel a bit more inclined to follow up with the team in the longer run. Especially, we need to understand that if we have operated on a 15, 16-year-old person, and if the NHS England's, what the NHS England service specs talk about is to have at least 5 years of follow-up, these children will no longer be children. They would be adults, they would be in the university, and they may leave their area working, or they might go and work, or they get married or and go away. So that is why it is important to make sure that we try to do everything in our basis to see whether they can continue to come back to us. And the measures which we have used is the Rosenberg self-esteem, because these patients do have low morale. We also look at hospital anxiety and depression scale, and we find that a lot of them have depressions. And we look at quality of life in children, and looking at their physical comfort, body esteem, social life, and family relations. The pathway which we have is that the patient gets referred to us. There is a joint clinic between a pediatrician, dietitian, surgeon, and bariatric nurse. They usually then come back for a day case admission if needed, to look at their ultrasound and bloods, and also to do a sleep study. I tend to do sleep study in all the patients which are coming for surgery. We at that point will have an MBT discussion, looking to see whether they are fit to proceed. And if all three of us have had, or four of us have had, this feeling that this patient is appropriate and wants to keen on surgery, we would then do the psychological assessment at that point, and then again have a joint discussion along with the psychologist. Once approved, the patient gets reviewed by the anesthetist and then goes for surgery. At King's, our referrals suddenly spiked almost to double the number in 2 years, between 2014 and 2016, as you could see. What we started doing was to send a diet diary which the patient had to send it to us. We also had more appropriate referrals coming through, but the patients were then discharged. Not all of them were found appropriate, because either they were not keen for surgery, or they failed to return their food diaries, or they did not attend. If they don't attend twice, we discharge them, because, as I said, if they don't follow up their advice before, they're unlikely to follow it later. We have mainly done sleeve gastrectomies, but have resorted to 2 bypasses and 3 bands in my patients. And as you could see, the numbers had started going up in 2020 when I left. And then I moved to Royal London, where the benefit which I have is that we have a very well established Tier 3 service, which is run by Dr. Jin Paed, who is also currently coordinating the pediatric obesity, the Tier 3 provisions across London. He works through the mayor's office and is trying to do good work there. We also have excellent pediatric subspecialty support with a pediatric endocrinologist, and they tell me that they have at least 8 type 2 patients with morbid obesity. And our pediatric respiratory team has high number of OSAs and around 12 with obstructive sleep apnea and who meet the surgical criteria. And I have a very supportive management. What we don't have, and which we are working currently on, is pediatric psychology, which I have outsourced because of the link, and our first 2 patients are now being assessed, so that we should be able to do the first surgery in a couple of months' time. We also do not have an adult bariatric service in Royal London or parts, but we are using the North Thames ODN network to solve that issue and to get appropriate support. And I have been lucky that I have very good encouraging conversations, and we should have somebody helping us very soon. So As I said, we already have 10 patients who are under assessment in various stages, and 2 of them are with type 2 diabetes. And 4 of them would be sent to the psychological evaluations. 2 have already been sent. But what we are lacking is a training for pediatric bariatric surgery, and I would request BOMSS to start working along with BAPS, which is the British Association of Pediatric Surgeons, where we should think in terms of how to develop the adolescent bariatric program, because it should be a joint approach done by the obesity surgeons along with the pediatric surgeons. But we have come a long way. In 2015, I went to American Society of Metabolic Surgeons meeting at the Obesity Week, and I was introduced to the president, who said, "Oh, Ashish, turn around. I want to see the dartboard, because I'm sure people are trying the dart on your back." And I said, "Actually, it is not the darts. People are actually trying to throw the spears." But the very fact that I am here talking uninvited by BOMSS shows that the attitudes are changing. The acceptance of adolescent bariatric service, or the need for adolescent bariatric service, is changing and is getting more approved. And therefore, all I can say is thank you. Thank you, BOMSS.
Thank you so much, Ashish, for a fantastic, thought-provoking talk. Can I take chair's prerogative and sort of ask a question to start with? So I think that we need a national centres for bariatric surgery in adolescents, but the big barrier is funding for that. So there was going to be a specialist commissioning several years ago, but then that never happened. Do you know where that process is at?
So as I told you, I have been working with the Tier 3 task force, and the discussions, which I think one of the reasons why it got stalled initially was because the thought was that unless we have an existing Tier 3 service, we cannot operate on these patients. And for example, at King's, what we had was a Tier 4 service of pediatrics, but we didn't have a Tier 3 service. We had 2 of my colleague pediatricians who took over that mental, and we treated them for a year. What I envisage is that with the Tier 3 service being set up, the patient's comorbidities will be all looked at in the Tier 3. They would then get referred to us, and we would do the surgery and make sure that we follow up these patients. So I think now that the Tier 3 is set up, there is a definite interest and inclination in increasing the setting up the Tier 4 service. As I've said, I've been speaking to the National Clinical Director for CYP, and they have also said the same thing. They had to, probably because UCL is part of the CREW team, where they had to increase the numbers. Initially, they were planned to have a Tier 3 service in 12 centers across as a hub, but now those numbers are going up because the pandemic has increased the percentage of obesity by almost 2% in young children, and therefore the numbers have gone up. So I've given a long-winded statement, but the fact remains, yes, there is definite interest in doing that in NHSE, though I cannot vouch for them.
So Ashish, because most of the people on this call are probably going to be adult practitioners, can you explain what the CREW centres are? Because I don't think most of the people on the webinar will know what they are.
So what has been thought is that we should have a Tier 3 service, and so these are the children's obesity Tier 3 centers, basically. So we have said that all these patients, the hub should have pediatrician, dietitian, and a psychologist assessing this, and so that the treatment or the diet and the exercise sets in right at that point. And only after they have done 2 years of the service, or at least appropriate length of it, that the patient should be then referred to us. So this is a tier 3 service, which technically adults should have had as well. But we all know that even that is, because it is CCG led, I think it is quite hit and miss. But that's the reason why NHS England has decided to do that as a national commissioning. There would be 12 hubs, and then there will be spokes in other centers, which will monitor the service in that area.
Thank you. Chetan, do you want to ask the first question?
Thank you, Ashish, for this excellent talk, and thank you for explaining this tier 3 and the hub and spoke model. On that line, before going to the chat box, I had just one question that, you yourself mentioned how when you started all this, that word or adolescent bariatric surgery was a taboo. And I know all your hard work and Rachel and all at level, you now have that tier 3. But do you think we still need to raise awareness at a public level or a GP level or somewhere, because that's where the original referral will come through? Or how can that be addressed?
So, as I said, I think 2 different things here. One is once we have a tier 3 service, I'm hoping that the patient pathway from the GPs and the community teams will be quite streamlined to go to tier 3, because there will be funding for that. Currently, what happens is the tier 3 service or the obesity management in the hospital is quite hit and miss. There are different specialists who manage these children. So in some hospitals, there are dietitians running that, some it is pediatricians, and some there are pediatric endocrinologists, and even pediatric nephrologists, because some of these patients have hypertension. So once this is streamlined, I feel that they will get referred to the pediatricians, and therefore they'll come to tier 3, and therefore it is easier pathway to come to tier 4. As far as the awareness goes, I'm doing my bits. So I am talking to the Pediatric Endocrine Society, and I think we all need to do our work, and quite happy to get involved at all the levels. I am also attending the all-party parliament group on obesity to see whether we can get some of the members from the parliament to support this cause. So yeah, I think that's all I'd say.
Thank you, Ashish. Coming to the question, I think the first question is from Roxana. How can trainees interested in adolescent bariatrics obtain suitable pediatric experience? Do we need a formal pediatric surgery placement, or do you think that skills can be obtained through those specialist bariatric placements alone?
As I said, I think I would be very keen on working jointly with BOMSS and BABS to get the pathway to get some formal training being set up. Because I think it is 2 different things. I think the surgical skills are easier to do. I think unless a person has worked in the pediatric setup, they would be still always reluctant. I don't think any one of you in this room is, all of you are capable of doing a sleeve irrespective of the size of the patient. The problem is that comfort zone of saying, yes, I can do this patient. And that is what will come unless people have to do the pediatric training. And I think they do need to do a pediatric training to get that approval. Once the service is up and running, I'm quite happy to think whether working with us in our center would help in getting that experience, because they can do pediatric bariatric service as well as pediatric surgery, because I still don't have the luxury of doing pure pediatric bariatric service. And I probably would not have till I retire in 10 years' time. But I think because we also need to look at the right mix, because when you look at pediatric neurosurgery, you cannot be a pediatric neurosurgeon unless you spend 50% of your time doing pure pediatric neurosurgery. And we don't have that specifications about doing pediatric bariatric service. And therefore, as I showed you in the numbers, most of the surgeons, if they are adult trained surgeons, they would be happy to operate on a 15-and-a-half-year-old patient or a 15-year-old patient. But when it comes to complex cases, they're all drifting down to me, where I'm doing 10 cases a year and others are doing 50, 80 cases a year. And so I think we need to have, to be honest, we should have some more talk about this outside this area. We need to get that service, and we need to put a thought about saying, yes, how can we work together? As I told you, I have done in the past, because I am the current secretary for British Association of Pediatric Surgeons. So I can assure you that BAPS definitely has interest in doing that and working together with BOMSS.
Can I ask the next question from Mary O'Kane? She wants to know, how successful are the team at encouraging adolescents to engage with a follow-up and have blood tests?
So it is quite interesting. What I initially in my King's practice, what I did was that I would see them in 6 weeks and then handed over these patients back to the pediatricians. And I saw that there was a sudden disinterest in the patients to come back to that service. And when I looked at the follow-up results and I said, this is obviously not sustainable, I sent them a request to come back to my clinic. And interestingly, every single patient came back to my clinic, because as I said, these patients move away from pediatrics to adult world. So when they get a referral to say, come back and see a pediatrician, they lose their interest. They have no interest in going back to the pediatrician team because they feel they've outgrown that service. But when they come to the surgeon who has done the surgery, they're very happy to come back and talk to the surgeon. So what I aim to do in Royal London is to make sure that every single patient comes back to the joint clinic where I'm part of it. And I have a feeling that they will come back. So I hope that answers Mary's question.
So on the same sort of theme, do you think then having it labeled as an adolescent clinic is more attractive than it being a pediatric clinic?
Well, the thing is, the adolescent didn't work, because at King's, we called it as King's Adolescent Bariatric Service. So I don't think the title makes a difference. Yeah. Because we never called it a pediatric service. Because if you look at the NICE guidelines and the NHS England specifications, they're all about making sure that the person is mature, i.e. adolescent. But when I was as a part of the team with the Paediatric Society or pediatric guidelines from ASMBS, which we rewrote in 2018, we have gone down to the age of 10 there. So the Americans are quite happy to operate at 10 once they have certain BMIs above 50, or rather who are way above 99.6 centile in their BMI charts.
On that note, if I may ask one question, I know it's smaller numbers and we are just setting up, but would you, from your experience of those 30, 40 patients, be able to say what is that ideal age where you would like to offer bariatric surgery in the way of physiological development, understanding, follow-up, and as a family, as a package? What do you think would be a good age?
It is something which is quite interesting, and I don't think I can stop answering that in next 5 minutes. What I would do is I will take a rain check, and I'll try to answer that in Brighton.
Okay.
So there's one more question from Dimitri. Should we aim for adolescent and young adult units / hubs to address training, collaboration, and the challenge of follow-up?
Short answer, yes. The longer answer, I have been in touch with RCPCH, because Royal College of Children do talk. RCPCH does say that the children, into inverted commas, goes up to 21 years of age. When I did mention this to some of the adult colleagues who have been doing pediatric or adolescent bariatric surgery, I didn't think that there was acceptance from the adult surgeons to work on that arena. So I think it requires a lot more work, probably more acceptance from all the quarters to make sure that it is the right thing. But I personally feel that yes, that is definitely the way to go.
So there was just another quick one that's on a similar vein from Andrew Beamish, basically saying, since most eligible adolescents are late adolescents, how do you feel about the concept of a young person's unit catering for 15 to 25?
Well, as I said, RCPCA talks about up to 21, but I think if you cater to 15 to 25, you have missed the boat. What will we do to this 13-year-old girl whose BMI is 63 and weighs 163 kilos, or that 14-year-old boy who is 215 kilos when he came to me? I think we need to go younger, and we need to relook at this guideline as the Americans have done, and we should be bold enough to go down and start operating them younger rather than wait till they're 14, 15, 16, 17.
And just one more question on that note. Yes, I saw you from your graph that sleeve were the majority of the case, and you had done 2 bypasses. Looking at the world literature around more and more, do you think now in Royal London, your first procedure of choice would be sleeve, or would you say you would be doing more bypass, and why?
I think that is, again, I was talking to Albert Alston, who did the EMOS study from Sweden. And what we were talking about is that isn't that the time ripe to start having a randomized control trial between sleeves and bypasses for children? Because we have not done that. And we are doing what we feel we should be doing. As I said, my concern about doing the bypass at 13 is how are they going to cope when they are 53, and what are we going to do when they get obese or 10% failure rate, which we have? What are we going to do about them? So that is the reason why and again, there is a data from Americans where though the patients always answer that yes, they are taking their multivitamins, they are not. So they put a microchip in their multivitamin bottles cap and found that only 10% opened that cap every day and others didn't. But when you ask them in the question, in their follow-ups, almost 80% said they always take a multivitamin. And what are we going to do when that girl who has had the surgery at 13 becomes pregnant and has vitamin deficiencies and therefore further problems in the child? So I think we need to have a randomized trial. Sorry, Rachel.
No, it's fine. I was just going to say it's now 8:45, and I'd like to thank you again for a fantastic talk. I'd like to call on everybody who's listening that this is an area that we need to push forward. We need to encourage patients who need to be referred and to really push every avenue to make sure that young people with obesity are able to access care. Ashish is going to be talking at BOMSS, so this gives me a chance to plug to please register for Brighton. Looks like a fantastic program which is now available. And finally, I'd like to draw your attention to the next journal club, which is from the Portsmouth unit on the 13th of April. So thank you to everybody. Thank you again, Ashish, and have a really—
Thank you very much. I really appreciate it.
Evening.
Thank you.
Thank you, Ashish, and thank you, Rachel. Good evening to all. Bye.
Thank you.